Coakley, Chair of the Oncologic Imaging Track, and we will get right started. The only real announcement is again to silence your cell phones and any other devices you have on. And with that, we'll get started straight away with the first speaker, Dr. Andrew Holodny, who is Chief of Neuroradiology at Sloan Kettering in New York. Andrew.
Okay, so Dr. Coakley, thank you very much for inviting me. Dear audience, thank you for attending. My name is Andrew Holodny, and I'm from Memorial Sloan Kettering, and this is Pitfalls in Oncological Imaging, Neuroradiology. So, an overview of what I'll talk about. First, I'll show some cases of PET-CT. PET-CT has become really the go-to imaging modality to follow up many cancers and lymphoma. And then I'll talk about some advances in GBM therapy, including temozolomide and radiation therapy, as well as Avastin or bevacizumab and its analogs, and how these therapies affect MR characteristics of these tumors, which now can be very challenging to read. And this is not a complete list, and since this is an oncological imaging course and I'm from Memorial Sloan Kettering, I will be focusing mostly on tumors. A case like this is a young man has had lymphoma, follow-up scan, and you see something like this, right? A whole bunch of areas of increase of FDG uptake on this FDG PET scan. There we go. Is this recurrence? You're not sure. Maybe. Look at the axial images there. They all are. Fancy schmancy reconstruction imaging with the CT there. And the key here, of course, is to look at the CT scan. And what you can see is that this is mostly fat areas here, mostly areas of adipose tissue. So this is brown fat. And this is a source of full positive results in about 3.7%. White adipose tissue, as opposed to brown fat, is used for insulation and energy deposits. And a brown or adipose tissue is for thermogenesis by uncoupling of oxidative phosphorylation. It's found in the neck, near large vessels in the chest, in the axilla, perinephric region, intercostal paravertebral region, kind of right where those lymph nodes sit that we're looking for when we're doing a PET scan and follow-up for lymphoma or something like that. Seen a lot in infants, children, and in women. Here's another case. This person had a nasopharyngeal carcinoma, which we can't see over here, but we're looking through the FDG of the neck. Here's the axial images, here's a coronal image, and one quick glance and you really don't see any big uptake anywhere. Kind of a normal study, right? Oh, look at this, right? There's a kind of a big lesion here if you look kind of carefully, right? Big lesion right there. Look carefully, and this is a necrotic adenopathy. And often when the lymph node is very necrotic and very big, you really don't see all that much uptake. So this is something to look out for. And again, you'll easily see this on the CT scan. This is a PET scan for a person with lung cancer. There's our lung cancer right there. There's the heart. And we have some uptake in the left side of the neck here. Kind of unusual. Kind of an unusual spread, right? Unusual spread of disease. Usually lung cancer spread, mediastinal lymph nodes, something like that. Neck lymph nodes only happen much later. So what does this represent? What does this represent? Well, you look at the CAT scan, and there's our lesion right here. And it's right at the tail of the parotid, and this is benign parotid pleomorphic adenoma, which should not be confused with lymph nodes. And if you look at the CT, you should be able to tell the difference. Here's another case. This is a pre-treatment PET scan. There's our primary squamous cell carcinoma of the tonsil, and it looks like we got two malignant lymph nodes on the left side of the neck. Completely normal. This is kind of how these things spread. Everybody's happy with this. Patient's treated, and what's going on here, right? Is there one lymph node left? That's kind of unusual, right? The squamous cell carcinoma goes away, this one goes away, then this one should go away too, right? So what's going on here? Is this a treatment failure? So again, we'd go to the CT scan. This is the treated lymph node. It's much smaller than it used to be. And over here, we have another lesion in the tail of the parotid, and that is pleomorphic adenoma. So the first one was benign pleomorphic adenoma, and they can accumulate FDG and fake you out if you just look at the PET part of the PET CT scan. Another case right here. This was again a head and neck cancer that was treated, and these are submandibular glands which accumulate FDG, and we have a lesion on this side and not a lesion on the other side. I'm a neuroradiologist, so I believe in the Sesame Street school of radiology. If one side has to kind of look like the other side, that's why I'm not good in body radiology. You got the liver on one side and the spleen on the other, and I get all confused. In neuroradiology, it's kind of simple. One side kind of has to look like the other. And if it doesn't, then I start scratching my head and worrying. So if I see a case like this, I got some big uptake over here on this side of the neck and no uptake here, well, I got to try to figure out what's going on in here. And is there a lesion in the right parotid gland? Well, we can go to other imaging studies. Here, this is a T1 weighted image. There's our parotid gland right here. This is a T2 weighted fat saturated image, normal looking parotid. And what do we have over here? So that's our normal parotid. And here, this is kind of the same signal intensity as that fat, right? This sats out just as this fat here. This is fatty replacement of a parotid lesion. So it's actually, this was probably had a head and neck cancer on this side of the neck. They zapped them with radiation, turned into fatty replacement. And so this is a normal uptake in the parotid gland on the right and atrophy on the other side. This happens very often, especially submandibular glands, things like that. You'll have a big uptake on this side, no uptake over here. Somebody incorrectly calls it, well, you got a huge lymph node in the submandibular triangle over here. No, that's the normal submandibular gland. Okay? So fatty replaced left parotid. So normal right parotid, fatty replaced left parotid. There's our normal parotid, fatty replaced left parotid. Often you get uptake in cases like this, and this is Hashimoto's thyroiditis. Other types of thyroiditis often give you uptake, so it's important to correlate these, and if it's in the thyroid, you're thinking of some kind of thyroiditis versus some kind of malignant lymph nodes in the neck. And this occasionally also comes up in a PET CT scan. I mean, this guy looks like a superhero. His muscles are really standing out. So what's going on here? And this person did an insulin injection right at the time, so that's another pitfall. So all the FDG goes to the muscles instead of going where it's supposed to be going, so that's another important thing. So you don't think this guy is, Flash or Superman or something like that. All right, so technical limitations of PET are it's insensitive to small volumes of tumor, melanoma recurrence at the primary site, or malt lymphoma, or salivary gland lesions. And FDG uptake in subjects may be variable, and we don't do a dedicated, so a PET CT is not a real dedicated CT scan of the neck, so we often get a dedicated CT scan of the neck with angulations and things the way we like them versus how it comes out with the PET CT scan. So moving on to brain tumors. This is an outline. I'll talk about some new therapies in gliomas, including temozolomide or temodar in radiation therapy, bevacizumab and Avastin, and some others. And I'll talk about how these therapies affect the MR characteristics to attempt to differentiate between the tumor getting better or worse and the image getting better or worse. This is a very important point which I'll stress during this presentation. So how to optimally collaborate with neuro-oncologists, with our colleagues. We have to know what they want to know and what you, as the radiologist, have to know to optimally interpret the images. So, when I was a younger man, the film library looked like this, and the films would get lost or mislabeled or stolen by the neurosurgery fellow or what have you. And now we've moved to PACS, and this is of course wonderful, but this creates its own problems. And, we used to read films as the MR scan went to the radiologist dictated a report, and that went right to the referring physician. So now, occasionally people want the MR to go right there to the referring physician with us not being involved. I was shocked that, some of my colleagues get a request like this, scan patients, send films. I don't think this is right, and this is, not right for the patient, not right for the patient. So, and what I think is, optimally we should be really communicating with the referring physician. But what's important is not only this way, but also it's important for the referring physician to communicate with us, to figure out what exactly they're interested in, what they want to do, and how we can optimize our own situation here. All right, so this is not the model we want to do. We want to do this kind of model right here. So, what's important for the neurologist in brain tumor oncology is, his question is the following. He only has two things he wants to know, he or she wants to know. One, is the tumor better or worse or the same? Two, and based on the answer to this, do I change the therapy? If the tumor is the same or better, he's going to keep giving the person, the patient, whatever therapy he's giving, and he's very happy about that. If it's not working for some reason and the tumor is getting worse, then he's going to think about changing the therapy. So this is the paradigm in the mind of the neuro-oncologist. And this is really the only question that we have to answer when we're looking at films of a patient with a glioma. Is it better or worse or the same? And this translates into, do I change the therapy? So I'm going to start off with a little quiz here. So I'll show you a couple of cases. And, this is your regular cases that you're reading during the day. And you come up, this is the old case here, let's say 6 weeks previously. This is the new case here. And you have to answer better, worse, or same. None of these will be the same. Better or worse. Now, you don't have to, write it down or say anything. But so this is the question, right? Is this progression of disease or is the patient getting better? All right, question number one. Case number two, right? There's a big butterfly glioma here, axial sagittal case. 6 or 8 weeks later, they get a follow-up. Better or worse? Just answer it in your mind. And how would you read this case? Is it better or is it worse? Okay. And this case here. So this is a flare abnormality. Patients had surgery, flare abnormality, some enhancement right here. Maybe 2 months later, gets a follow-up examination. There's the flare. 3 months later, I'm sorry. There's the enhancement. A little bit more flare, a little bit less enhancement. Better or worse? Right? If you say there's less enhancement, more flare, well, that doesn't help the oncologist out at all. How about this one? Post-gadolinium, flare. Patients had surgery here. 3 months later, post-gadolinium, flare. Better or worse? Better or worse? How about this one? So there are 3 scans here. Flare enhanced, flare contrast enhanced, flare contrast enhanced. Which scan came first? Which scan came second? Which scan came third? And by the end of this talk, you'll be able to figure this out. That's A, there's B, and there's C. All right, so these aren't easy questions, and now we'll go through a formal way how to attack these cases and to figure out what's actually going on in these patients. So, glioblastomas, 10 years ago, things used to be easy, right? The clinical prognosis was dismal. GBM survival, 12 to 14 months. If you had a recurrent GBM, you had a 9-week survival. Therapy, the only kind of sort of effective therapy was radiation therapy. Radiologically, it was very easy to read these cases, right? People used what's known as the McDonald's criteria, essentially 2 linear measurements of the enhancing part of the tumor. More enhancement, worse. Less enhancement, better. Very easy to read. That's how things were, say, about 10 years ago. So these are the McDonald's criteria, complete response, everything went away, partial response, 50% less enhancement, stable disease, stable progression, more than 25%. So what you would do if you were reading these according to the McDonald's criteria, you'd draw 2 lines, one this way, and you'd add them up, and that was your answer, and you'd compare it to the other enhancing lesions. So you look only at the T1 post-gadolinium images according to the McDonald's criteria, right? So you don't look at the flare, you don't look at the T2, you don't look at diffusion, perfusion, spectroscopy, all these other toys that we have. And Dr. McDonald was a neurologist, by the way. And there's great variability about how to draw these lines and what have you. So now in 2005, a really important study came out having to do with temozolomide or Temodar. This was by Dr. Strupp. This was actually a landmark study. He had 573 patients in 85 centers. This was double-blind, prospective, multi-institutional, every positive adjective you could use here. So he compared radiation therapy to temozolomide and radiation therapy. And there was a significant increase in the survival. For example, 2-year survival went from 10% to 27%. Still miserable, but 3 times better than it used to be. And this became known as the Strupp protocol, and that's kind of the standard still to this day, unless you're involved in some kind of study. So, but what happened is we came across this phenomenon known as pseudoprogression. So it's not real progression. Actually, the patient's getting better, but you get MR characteristics that look like the tumor is getting worse. So pseudoprogression is worsening of the MR features within the first 3 months after therapy by temozolomide and RT. Defined as, again using McDonald's criteria, as a 25% increase in the volume of enhancement, which later either stabilized or improved without initiation of new therapy. So what happened is you kept the patient on the therapy he was on, and the enhancement either got smaller or stayed the same, which basically proved that this was not really progression. This was just some MR characteristics getting worse, whereas the tumor actually was kind of getting better. So this can occur in approximately 20 to 30% of the patients treated with temozolomide and RT, and can explain approximately 50 to 64% of enlarging lesions after completion of therapy. So, if I'm using my old 10-year-old criteria for reading these films, I could be wrong in 64% of the time. That's not good, right? That's worse than flipping a coin. So we're going to hopefully avoid how to do that. So here's an example of pseudoprogression. Article in Lancet Oncology. This is the first case. This is a follow-up after radiation therapy and temozolomide. So, how do you try to figure this out? Sometimes it's extremely difficult. Often it's impossible to figure out between these two things. But sometimes there are hints. See, for example, there's really no enhancement here in this. There's a lot of edema, really no enhancement. Here there's a lot of new edema, and actually the cyst has gotten bigger where the mass effect is kind of sort of about the same. So if you have even if you have like a grade 3 lesion that they treat using the Strupp protocol, and there's suddenly a lot of new enhancement, that's either very malignant transformation that's really, really bad, or it's pseudoprogression. Okay, so then 3 months later, this is what it looks like keeping the patient on the same therapy. All the enhancement went away and the cyst got bigger. Okay, so if you have something like this, put the patient on temozolomide and radiation therapy. It looks like this. You really have to think about pseudoprogression versus real progression. All right. So what this means is that it is essential for the radiologist to know with what medicines the patient is being treated. If you don't know this, you'll get this answer wrong. All right. So that's why send films, scan patients, send films is really not good, never was good. Now it's really unacceptable. And it's important to keep, a relationship with your neurologist to try to figure out what this new enhancement means for the benefit of the patient. Okay? So we all know things about like classic radiation necrosis. This was described in a classic paper by Norm Leeds and his gang. So a classic radiation necrosis happens approximately 1 year after radiation therapy. This is before the era of temozolomide, with a range of 3 to 48 months, a median of 12 months. Incidence is 3 to 24% in GBMs, and can be differentiated, well, sort of, from progression to a certain degree by maybe spectroscopy, perfusion, FDG PET, possibly these new FLT or C11 methionine. Pseudoprogression, on the other hand, happens usually at 1 month after initiation of this therapy, and up to about 3 months after radiation therapy and temozolomide. Incidence is 20 to 30%, and whether it can be differentiated is kind of really unknown. right? So pseudoprogression versus radiation necrosis, this is probably a continuum of the same phenomenon, probably a continuum. It's induced by pronounced tissue reaction with an inflammatory component, edema, and abnormal vessel permeability, causing new or increased contrast enhancement. The addition of temozolomide causes post-RT changes to develop earlier and more frequently. Okay, so whatever temozolomide is doing to fight the tumor is probably the same thing that's causing this reaction and causing radiation necrosis to appear earlier, and that's being called pseudoprogression. So the mechanism of action is very complex and not understood well. So radiation therapy is DNA and membrane damage, temozolomide is DNA damage, appear to be synergistic, which is why they work together, may activate parallel molecular pathways causing increased endothelial cell death, and probable reason for increased efficiency of this paradigm, and the possible reason for increase in pseudoprogression or an MR marker for increased vascular permeability, hypoxia, and cell death. So clinical implications are between pseudoprogression and real progression is crucial, right? Do I keep the patient on the same medicine if it's pseudoprogression, or do I change medicine if it's real progression? Crucial difference. Patient may actually be getting better. Keep the patient on the therapy versus patient getting worse. Change the therapy. Right, so standard MR really can't differentiate these two. There's a paper by Rob Young from our group. So when present, the only difference he found was subependymal spread of enhancing lesion is a useful MR marker for identifying early progression rather than pseudoprogression. So if you have like some subependymal spread this way, then that's probably a mark. Everything else looked exactly the same. No statistical difference in Rob's study. So the McDonald's criteria was modified to what's known as the Raynaud criteria, and without going through this, they basically take into effect the ideas of pseudoprogression. So clinical implications, progression versus pseudoprogression, you know, perhaps in perfusion there appears to be some differences, but there is a significant overlap between the two findings. I'll show you some examples. Here's a case. So this guy has had surgery, a little lump of enhancement pops up, progression or pseudoprogression. Here, you know, the lump is getting a little bigger, surgical cavity is getting a little smaller, you know, lumps maybe getting a little bit bigger. We did a perfusion, and then that's actually the area of the perfusion which was low, so we thought that this was pseudoprogression, and in the follow-up he actually got a little bit smaller, so this happened to be right. And this is a T1 perfusion for GBM. And the plasma volume was very bright, and the K-trans was very bright, and we thought that this was more in keeping with tumor progression. That also happened to be right. So generally, we've gone to T1 perfusion and really don't do T2 star perfusion anymore. You know, there's some artifacts in T2 star perfusion, misregistration. If you have surgery, it wipes out. There's a susceptibility artifact that wipes out the signal, and T1 is much better than that. Just kind of an aside, we've started to do perfusion of spine lesions, and I think this is really going to change things, right? This is, you know, everybody can see this is a metastasis here. I mean, that's a really easy call, right? So the perfusion is very hot. I'm sorry, but these arrows always keep misregistering. Now, this is a follow-up examination here. Now, what's going on over here? You know, I'd have a really hard time reading this case, right? The vertebral body's collapsed. You know, what's all these changes here? What's all the changes in the vertebral body above? Is there new epidural disease? Is there some kind of stuff in the posterior elements here? You know, what is this? Is, you know, collapse and arthritis next to this versus a recurrence of the tumor? I'd have a really hard time really reading this. And perfusion really makes it easy. All right, there's no recurrence here. It's really dark, and there is actually a recurrence in the posterior elements. There, if you look at the perfusion, it's really easy. So this is stuff that's in the works, but it's stuff that will be coming down the pike soon. So, kind of to review, temozolomide plus radiation therapy improves survival, occurs earlier than radiation necrosis. Be aware that this occurs. An increase in enhancement and an increase in flare does not mean progression. Okay, this could be pseudoprogression. It's essential to know the history, and if you do not know the treatment history, you really shouldn't be reading these scans because you'll be making mistakes, and you don't want to look bad and say things that'll be not optimal for the patient's care. All right, so this is a case of radiation necrosis. So is this a case of pseudoprogression? There's the tumor. So if you look at the, just the size of this lesion, it went up, but all the center is necrotic. So we should be able to see that this is, this was the area of radiation therapy. Follow-up looked like this, and then the other follow-up looked like this, kind of went away. What's interesting is this guy, they showed this as a case of pseudoprogression, and I showed it to my guys at work, and they all said, no, this isn't progression. We'd all call this improved therapy. So there was no radiologist on this paper. Any neuroradiologist would have picked this up. So there still is, work for us to do. And this tumor recurred outside of the radiation field. So, pseudo-progression is kind of when somebody doesn't know how to read the films. Anyway, so Avastin, or bevacizumab, is pseudo-response. It's an apparently effective anti-tumor drug, and effective against many types of tumors. Its use is skyrocketed. It's very expensive. So what happens is you get tumor growth, increased demand for O2, you get hypoxia, HIF-1 alpha. This promotes VEGF, tumor neurovascularity. Increased blood flow allows the tumor to grow. So what happens is Avastin hits it right here. So there's, in theory, no increase in tumor neurovascularity and no increase in the blood delivery to the tumor, and the tumor growth should stop. Occasionally it works, occasionally it doesn't. So this is kind of what it does. And there is some encouraging clinical data in GBMs, but there are no prospective double-blind studies of yet. Mechanism of action is unclear. The question is, does it actually affect tumor growth, or does it act as a supersteroid, so it just kind of makes it look better? And the optimal protocol or combination with radiation therapy or other chemotherapy is not yet established. Effectiveness of Avastin, this is the GBM. 1 year later, no change, stone cold normal. Perfusion, stone cold normal. If you got a GBM, this is what you want to look 1 year after therapy, all right, on Avastin. So what's the problem? Now, the problem is that it affects tumor neovasculature, makes the tumor better, but also affects vessel-related characteristics, permeability, blood barrier breakdown, edema. Consequently, it is difficult to differentiate between actual improvement and the secondary effects of Avastin. And this is known as pseudo-response. So it's not real response, but pseudo-response. This is an Avastin, but something analogous to it, by Tracy Batchelor and Greg Sorensen. So this is 5 days before treatment, 1 day before treatment, 1 day after, 27 days, 57, 111 days. Right? So before treatment, there's a big enhancing lesion here, permeability is very high. They give this medicine. 1 day after, the permeability goes away, normalized in 1 day after. Now, we all know that Greg Sorensen is an extremely bright guy, but even Greg can't cure a GBM with one drug 1 day after, right? So this is the effect of the medicine. This doesn't mean that the tumor went away. It's just changed the MR characteristics to make them look better, all right? So this is what typical case looks like. The patient had a tumor here, recurred over here. There's enhancement there, increase in perfusion. The flare looks this way. The effects of Avastin, the enhancement goes away. Perfusion is normalized, but the flare gets worse. So the non-enhancing part of the tumor has gotten larger. That's how Avastin fails in gliomas. Okay, so kind of the low-grade non-enhancing part of the tumor starts to grow because Avastin doesn't affect that part. Okay, here's another example. Patient had a tumor on this side, recurred over here, was given Avastin, enhancement goes away, but the flare gets bigger. So the non-enhancing flare-positive part keeps on growing where the enhancement goes away. Classic pattern of a GBM on Avastin. So our case of better or worse, right, so this is progression of non-enhancing disease. Even though the enhancement went away, right, the mass like flare abnormality is bigger, right? You can tell that there's much more stuff here than there used to be before. So this is progression of disease, progression of non-enhancing tumor. Same thing over here, right? So this is the enhancement went away. By the kind of the nodularity, flare abnormality got worse. And in terms of first, second, and third scan, this is the first scan right here. Gave Avastin, enhancement went away, and the tumor is actually, the non-enhancing tumor is progressing over here. Okay? So a couple of examples, Avastin success, got much better, and failure. If you're on Avastin, you get new enhancement. That's a really horrible sign. Really horrible sign. It means the tumor is so strong, it's blasting through the effects of Avastin. Now, metastases stop enhancing when the patient's given Avastin. I remember I was reading this case on some Saturday, and all these new lesions popped up in this case with a patient with lung cancer, and none of them were enhancing. I thought, what is this, like cysticercosis or something? I was completely confused. And then, you took away the Avastin, and then they all start enhancing. So metastases don't enhance in the brain when the patient is on Avastin. So Avastin, possibly in combination with other drugs in NFRT, possibly improves survival, affects the MR characteristics. The K-trans goes down, the enhancement goes down. Be aware that this occurs rather frequently. So decrease in K-trans, decrease in enhancement is not equal to improvement if the patient's on Avastin. And the first post-Avastin study can sort of serve as a new baseline. Raynaud criteria has also adopted this. And, I'm running late. I'll kind of skip through this. So, in terms of another practical pitfall is the role of the radiologist in interpreting images. I believe it's a central role. All right? We must not only describe the findings, but actually interpret these findings. Saying increase in the volume of enhancement is a meaningless statement. Is meaningless, right? In the setting of Avastin therapy, such and such findings imply such and such is a meaningful statement that will help the neurologist actually do something better with the patient. So what we need is improved radiological markers for various disease and processes. And if we do not interpret the imaging findings, not just describe them, actually interpret them, others will do this for us. Thank you very much.
Excellent, thank you, Andrew. So we're going to move on now and look at some pitfalls in body imaging. And a few years ago, the Costco Busan ran into the Bay Bridge in San Francisco Bay, and there was a fairly sizable oil spill. And there's a reason I'm showing you those images, which I'll explain at the end of my talk. As we know, medical errors are under scrutiny, a lot of attention being paid to this, and within our own specialty, it's estimated that there are serious errors in 1 to 2.6% of radiology reports. So this is a big deal, and anything we can do to recognize and avoid these mistakes and pitfalls is clearly a good thing. In half an hour, it's obviously impossible to do anything comprehensive, so I'm going to just pick 5 topics that I think are particularly important in body imaging. And I wish I could say that Andrew and myself coordinated our talks. We didn't, but a lot of what I'm going to tell you will complement things that he said, so I guess it's better to be lucky than good. So things need to make oncologic sense, and this is really speaking to the need to integrate the clinical and past imaging of the patient into your interpretation. And I'm going to show you 3 examples of this and explain them each in a moment. So these are real-life examples. 64-year-old woman, history was breast cancer. Here's the report, big breast mass, axillary nodes, probably retroperitoneal nodal metastasis. And, I think you can see how that report might have come about. Here's a second one, 15-year-old girl, the history said prior neuroblastoma, positive PET scan. These hypervascular liver lesions were therefore called metastases. Another case, 64-year-old man with prostate cancer. This sclerotic lesion in the bone was read as probable metastasis. And, I think at first glance, any of those reports could seem reasonable, but let's look at them in a little bit more detail, because there was missing information. In the first case, the patient had a lumpectomy and a lymph node dissection 2 months before the CT, so those changes in the breast and axilla were likely just post-operative. Patient also had a history of drug abuse, Hep C, actually had a negative PET scan, so the nodes in the abdomen, those retroperitoneal nodes, were likely reactive, not metastatic. So by actually doing a little bit of due diligence and integrating this information, which is usually available and may take a little bit of work, but you don't have to do it in every case, but in these difficult cases it's worth doing because it's really going to add value and utility to your report and the information you're providing the referring physician. The second patient, when you actually looked at the history a bit more, it turned out the PET was done because she had a finger exostosis. Not sure why they decided to do a PET for that, but and this was the PET hotspot. It was unrelated to the liver. We never explained it. Maybe it was muscular. There was no imaging cross-sectional correlate to that finding. The MRI of the liver done after the report that was read as metastasis actually showed those hypervascular liver lesions were classic FNHs. So again, by doing a little bit more work, you can totally change the report and the interpretation. The last case I showed you, the sclerotic lesion, the missing information was that the patient had a PSA under 10, had Gleason 6 and only 5% of 1 of 12 cores, so a very low-risk patient. And if you look at the literature, the likelihood of that patient having bone metastasis is negligible. And whatever that thing was, maybe it was an enchondroma or something, probably not a bone metastasis. And when you think about our specialty, we are meant to be diagnosticians, which means we're meant to use knowledge. And the knowledge that is critical, I think, is the past history and the other imaging findings. And if we don't integrate that information, we're really not adding value, and we just become, describers, and that's not going to maintain our specialty as we look to being much more of a value-based healthcare system in the future. So again, imaging findings in cancer, you really do need to integrate those findings with the available information to make sure that it makes sense and is consistent with that other information. Okay, pseudoprogression. You saw some examples in the brain. I'm going to show you some body examples. Image on the right is a patient who'd been treated for melanoma metastasis, and at first glance you might say, oh look, here's a new hypovascular metastasis, but if you look closely, it was actually present as a hypervascular nodule in the baseline CT. And this is an example of pseudoprogression due to tumor devascularization, which I do think we see more commonly now with anti-angiogenic treatment, just more effective treatment in general. This will happen. Here's another example. Patient with pancreatic cancer, again, at first glance, you might say new liver lesions over here, but the patient's CA19-9 had actually gone down, so seemed like biochemically they were improving. And if you look more closely still, you'll see there's a solid pulmonary nodule that turned into a cyst on treatment. So this was probably, again, pseudoprogression due to devascularization, and these apparently new lesions were probably present but isodense on the baseline. Another example, slightly different mechanism, 50-year-old with pancreatic cancer. 1 month after finishing treatment, you again might be tempted to say new liver metastases, but if you look closely or if you're at the front of the audience, you can see these were actually very subtly present here, but they were largely obscured by fatty liver, probably from 5-FU treatment. Again, another example of pseudoprogression, slightly different mechanism. Here's one that we just did a little study on at OHSU. Patient with a new hotspot in the liver at the end of chemoradiation for esophageal cancer. We've actually found this in 9% of our esophageal cancer patients, so it's actually fairly common. And when we look at the CT, you see it doesn't really look like a metastasis, it has sort of straight margins. This is an example of radiation hepatitis. So again, a lot of different mechanisms for new lesions in cancer patients. They won't all be progression. So again, not all new lesions in patients with cancer are due to progression. You do have to think carefully and ask yourself, could it be pseudoprogression? Now I want to talk a little bit about atypical pancreatic masses, in particular atypical masses in the pancreatic head, which nearly always cause biliary dilatation. Once in a while, depending on location or whatever, you'll see a pancreatic head mass that is an adenocarcinoma that is not causing biliary dilatation, but it's extremely unusual. So I want to focus particularly on that. There are other atypical features and things to think about here, but time doesn't allow me to go into all of those. So some examples: 55-year-old alcoholic, had epigastric pain, had this very dilated pancreatic duct, some calcifications, looks like chronic pancreatitis, but had this, sort of vagoma mass in the pancreatic head. There is no biliary dilatation. This was biopsied. It was called adenocarcinoma. which would be unusual. Again, a mass here really, if it's an adenocarcinoma, should be causing biliary dilatation. This guy was alive and well 4 years later, so the pathology was reinterpreted and was described as just inflammation, no cancer. Here's another one, a 56-year-old man, abdominal pain, weight loss, ex-drinker. I was actually reading this follow-up CT. He'd had 4 courses of chemo for quote-unquote biopsy-proven adenocarcinoma, but there was no Bill-Dill. So I went back and looked at the baseline. There was no Bill-Dill, and really unusual for this to be a pancreatic adenocarcinoma, no biliary dilatation. So I asked the pathologist to look at the specimen again, and it was reinterpreted and called benign. So this is the only patient I've cured of pancreatic cancer. Probably with groove pancreatitis, looking at that in hindsight. 49-year-old man with abdominal pain, very sort of vague mass in the pancreatic head, no biliary dilatation. This guy proceeded to Whipple's, and the diagnosis came back as autoimmune pancreatitis, which apparently on a national level is the commonest cause of a benign Whipple's pathology, is the pseudomasses due to autoimmune pancreatitis. So again, the message is if you see a pancreatic head mass without biliary dilatation that's been called an adenocarcinoma, either radiologically or even pathologically, you should be suspicious. And pancreatic cancer misdiagnosis is probably commoner than we realize. If you look at these long-term survivors of patients who had Whipple's for alleged adenocarcinoma, you see about 10% of them will be called not cancer on pathologic reinterpretation. A lot of patients who go to, not a lot, but again, about 10% or a bit less of patients going to Whipple's get a benign diagnosis, often autoimmune pancreatitis. Interestingly, if you look at the American Cancer Society, they tell you the 5-year survival for pancreatic adenocarcinoma is 6%. If you look at data out of Sloan Kettering, it's only 1.8%. So, it's unlikely that patients do worse at Sloan Kettering Cancer Center. And probably what's happening here is that this data is contaminated by misdiagnosed neuroendocrine tumors, chronic pancreatitis, other things that are inflating this survival number. And if you have good pathology, your 5-year survival is even more dismal than it is otherwise. And one could argue that we should require imaging pathology concordance for the diagnosis of pancreatic carcinoma, much as we do, for example, in breast cancer. So again, pancreatic head mass without significant ductal biliary dilatation, probably not a pancreatic adenocarcinoma. Okay, now I want to look at some pitfalls in the pelvis in patients who've had proctectomy, because there's a few different pseudotumor mechanisms that can happen in that setting. This is a 64-year-old man who's 6 months after abdominoperitoneal resection. Would you call this recurrent rectal cancer? There's this big mass here sitting in front of the sacrum. But look closely, you see these somewhat symmetric structures here at a higher level, and there's this tubular structure heading out here. This is the ductus deferens. This is simply the displaced prostate and seminal vesicles that just sort of fall back into that presacral space in men. In women, the uterus will fall back here. So again, this isn't the big cystic necrotic mass. This is the uterus with the endometrial cavity, and this is the cervix slightly more inferiorly. And if you don't believe me, here is the T2 sagittal MRI showing here is the uterus that has fallen back into that presacral space after abdominoperitoneal resection. There's a few fibroids in here as well. And this is a recognized pseudotumor. Just need to know about it and not fall into this pitfall. Here's a slightly different mechanism. Again, 62-year-old man, 6 months after abdominoperitoneal resection for anal cancer, has a slightly strange, almost feathery looking mass in front of the sacrum. Doesn't have the typical appearance of the prostate, which is actually here, and this mass is here. But then when you look more closely, you see this very odd vessel coursing backwards through the pelvis, not any normal vessel that we would expect in that location. And this is an example of a transposed rectus abdominis or peritoneal muscle flap done occasionally to reduce peritoneal morbidity. After abdominoperitoneal resection, they take the muscle and flip it back. Here's another one. This is in the early post-op period, and they can look a little funky, especially early post-op, but again you see that inferior epigastric coursing back, this sort of band-like structure, that could be quite puzzling, but it's a transposed rectus abdominis muscle. Again, something to know about because they can definitely be quite confusing on imaging. So again, think about the various pseudotumor mechanisms for apparently local recurrent tumor after proctectomy. And finally, I want to talk about what I call linitis plastica of the ureters, which is something we've recognized, or at least I've come to know about in the last few years. This is a 70-year-old woman with abdominal discomfort, and you can see this bilateral hydronephrosis, yet there's really no adenopathy or masses in the retroperitoneum. She does have peritoneal carcinomatosis, and she also has something up here. Second similar case, this was a 75-year-old man who'd been stented by the urology service for some time for what was called retroperitoneal fibrosis, and you can see the somewhat atrophic kidney with a decreased nephrogram. There's a stent in place. The other side is hydronephrotic. But again, there really isn't any mass in the retroperitoneum. There's maybe some thickening of that right ureter. And both of these cases are example of malignant infiltration of the ureters by metastatic disease. This patient had lobular breast cancer, proven mets to the ureters. And these are basically radiologically occult because it's an infiltrative metastatic involvement. This patient turned out to have antral gastric cancer, which is why this image was up there, again with mets to the ureters, not retroperitoneal fibrosis. And so let's talk about linitis plastica, if you will, for a moment. The classic description was of this net-like submucosal infiltration in the stomach. It wasn't even known to be malignant until later on. The terminology, even though we apply it to, the water bottle leather stomach from metastatic breast cancer or from serous gastric carcinoma, the term has been, and I think appropriately so, used more widely for any infiltrative intramural cancer in a hollow viscus, and we definitely see this in other organs elsewhere in the GI tract, or indeed, as in these cases I showed you, in the ureters. And it's interesting, if you look at patients with breast cancer, we found this pattern of metastatic spread in 12.5% of patients being followed for lobular breast cancer. And if you look at the spread patterns of lobular breast cancer, it does like to spread to surfaces. So even though it only accounts for 15% of breast cancers, it accounts disproportionately for patients with meningeal spread, pleural spread, peritoneal spread, and this type of metastatic involvement of the ureters, infiltrative intramural spread, disproportionately due to lobular breast cancer. Here's some more examples. 78-year-old man with elevated liver function tests, has what you might think of as almost a UPJ-looking kidney. Turned out he had metastatic spread of pancreatic adenocarcinoma to the ureters with malignant infiltrative involvement. And here's another one, again, bilateral sort of UPJ-looking situation. This turned out to be metastatic GE junction adenocarcinoma. And then finally, this is one I saw just in the last few weeks. A 72-year-old woman, again, it is lobular breast cancer, so you should be thinking about this pattern of spread, these obstructed-looking kidneys, and had malignant infiltration of the distal ureters bilaterally. So, again, something to think about because there won't be much to see on cross-sectional imaging other than the hydronephrosis. The actual malignant infiltration itself is rarely, really visible. So again, when you see unexplained ureteral obstructions, particularly in older patients, patients with known malignancies or even occult malignancies, think about this pattern of spread that I call linitis plastica. So to sum up, there are obviously many sources of error in cancer imaging. Awareness is the key to correct interpretation, and it is always worth considering any kind of mimic or fake out or pitfall first. And the reason I showed you this at the beginning, the Koska-Busan, it really is a good example of how a misassumption or a first impression that is completely wrong can take you down the garden path. So what happened was it was a foggy day on the bay, which is common. The guy was the pilot was navigating under instrumentation. There is a transponder on the Bay Bridge which is on the towers, but the pilot thought they were in the center, so he navigates for here, but of course goes smack into the tower here. And because he never questioned that initial assumption, led on to disaster. And so again, always think about the possibility of some kind of pitfall or fake out first. And this is a piece of shameless self-promotion. So thank you for your attention. And we are doing well on time, but we'll keep questions for the end, and we can take all questions collectively. So we'll move on now to Dr. David Panasek again from Sloan Kettering, who's going to talk about musculoskeletal pitfalls.
Thanks, Fergus. So we're going to focus now on bone and soft tissues. And it's an important topic because whether you like bones and soft tissues or not, they're present on almost every image that you interpret. So it's important to be comfortable with them, at least in their common manifestations. So in this talk, what I'd like to first go over some imaging pitfalls and limitations of the various methodologies in characterizing bone and soft tissue lesions. And we'll also go over some post-treatment imaging pitfalls. So let's start with technical pitfall limitations. I think it's very common practice for most radiologists to look at bones on bone windows. It sounds like the normal and natural thing to do. But in reality, because those are such wide windows, you can miss things such as metastatic infiltration of the marrow. In some bones which predominantly contain fatty marrow, such as the femoral shafts, which are often included on pelvic CT scans, it's relatively easy to pick up abnormal changes in the marrow if you use the soft tissue windows. Similarly, over-reliance on the appearance on bone windows can lead to misdiagnosis of lytic lesions. For example, a common area that's overcalled is the sacral ala. In this case, on the right side, it was called a metastatic lesion. But in fact, when you put cursors on it, on soft tissue windows, it's even more apparent that this is nothing more than fatty marrow in an area of osteopenia. Then there's the issue of which images are you actually looking at. In this particular case, I use this example because it's a chondroblastoma of the epiphysis of the humerus, and I often walk into the reading room with my fellows and find that they've turned off all the parameters on the images, and then I ask them, what image are you looking at? And they often can't tell me, and I too would have difficulty. So I encourage you to leave the parameters on and to pay attention to what type of image you're looking at. For example, if I asked you which are the T1 proton density, T2, and T2 fat sat images, how easy would that be for you? Well, one of the ways to detect that is, in this case, there's a lot of marrow edema present due to the chondroblastoma. So edema shows up as areas of low signal on T1 weighted images, and on FATSAT T2 it would be high. But now I'd ask which is the proton density and which is the T2 non-FATSAT. I think it's very hard, if not impossible, to tell. But the real issue also is that when you look at those areas of marrow edema, there's no contrast between them and the adjacent marrow. They're invisible. And that's because both the marrow edema and the fat are relatively high signal on those images, and there's no contrast. So those are two sequences to avoid when trying to assess the marrow. Another limitation of radiography is that it tends to look for or does demonstrate trabecular and cortical destruction or blastic changes in the trabeculae. And you have to have considerable destruction of trabeculae, at least 30 to 50%, before you can actually see the lesion. This was a patient with melanoma, and when you look at the films, most of us would probably call it normal. On a very, very good day, if you happen to magnify this and focus on this area for a while, you might notice that there's some little calcific fragment. And on a really, really good day, you might notice that there's some unusual soft tissue projecting superiorly, but I doubt that. I know I wouldn't have found that prospectively. But in an instant, you can detect the marrow replacement on the MRI. Notice that it's important to remember the difference between the two techniques. Plain radiographs, just like CT, tend to focus on the trabecular changes and the cortical changes, whereas on MR, you're really not looking at those as much as you're looking at actual replacement of the bone marrow by tumor. And one example of this is in patients with myxoid liposarcoma, where at autopsy, it's common to find metastases in the marrow, yet prior to death, they were rarely identified, at least in the past. And that's because the patients had no symptoms, and both the radiographs and the bone scan were normal. And that's been known for decades already. And why is that? Well, here you can see this large liposarcoma in the thigh has some increased activity at FDG PET. There was no evidence of lesions in any of the bones. Yet when you looked at the MR, it was quite clear that there were numerous metastases throughout the spinal marrow with the typical halo signs. And the point here is that the deposits are in the marrow. They're not destroying trabeculae. They're not causing sclerotic changes, so they're not apparent on conventional imaging studies. Another limitation, MR can certainly show us a large mass, tells us a tremendous amount about the tissue composition and invasion of bone, but none of us would have recognized that, in fact, this is a heavily ossified mass present. Turned out to be a synovial sarcoma, but even large amounts of calcification can be inapparent on MR. Perhaps this area is one dense calcification. Another common pitfall is that I've noticed that many of my trainees and some faculty will focus on the T2 weighted and gadolinium enhanced images when trying to assess involvement of adjacent vessels. And when you think about it, the primary thing you're assessing when looking for an invasion or encasement is, are there preservation of fat planes? So it doesn't make sense to look at fat-saturated images when you're trying to specifically look at a fat plane. Here's the corresponding T1 weighted image, and you can see that this bone tumor is not at all contacting the vessels, where we would have said there was at least moderate contact on these others. So when you look for fat planes, look on T1 non-fat sat. So let's focus now on some pitfalls in lesion characterization. This patient presented after being in a motor vehicle accident, and the radiologist reporting this somewhere dictated this is an 8 by 3 centimeter heterogeneous fluid collection, likely representing a hematoma. And you can see why they might say that. There's some areas of hyperintensity within it, and it would fit with the history. But what's missing was any recommendation of follow-up to resolution, and instead, the patient presented 9 months later. The mass was considerably larger, and this was a synovial sarcoma, which, as you know, often contains areas of hemorrhage, and it can simulate a hematoma. So it's important not to overly rely on the history as the overriding factor in your interpretation. This patient presented with a mass in the thigh. You can see the marker placed over the region of palpable abnormality. And on T1 weighted images, it's a relatively well-circumscribed mass, but unlike most tumors, it tends to be hyperintense relative to the muscle. And on STIR imaging, it was totally homogeneously hyperintense, and on sagittal images, we can see there was a blood fluid level. But of note, there was considerable poorly defined edema around this. So we know this is not a typical simple cyst, for example. And on the gadolinium images, we can see the fluid level again, but of note, the wall is a little thicker than one would expect for the average hematoma. But this was called consistent with hematoma. At 3 months follow-up, at least at this level, it has a dark rim. You could say this is hemosiderin in the rim, although there's some enhancement. And we can see a subtle fluid level present within it and no internal enhancement at that level. So if you only looked at these, it'd be easy to say, yes, this is still turning into a chronic hematoma. But when you look more carefully at other levels, there was some nodular enhancing tissue. So right away, this is not typical of a simple hematoma. And at this point, they had presented to our institution, and we had the more of the images. And of course, when you're given the history that 1 year earlier they had this predominantly cystic appearing sarcoma in the pelvis with nodular enhancement, it became clear that this was a metastasis of this sarcoma to the thigh rather than a simple hematoma. So it's important to be aware of the patient's history and also follow strict rules of before you call something a cyst or a hematoma, make sure that it really conforms to all of the requirements. Another pitfall in characterizing mass is that some may appear deceptively benign and some appear almost cystic in appearance. I'll ask you to think which of these would you say is malignant, which would you say is benign? Are they both benign, both malignant? Which is which? And the answer is that A is a benign intramuscular myxoma, despite the presence of these somewhat irregular septi. And the more benign appearing one with just a few thin linear septa in the pelvis is a fully malignant myxoid liposarcoma. And the key to the diagnosis is, in avoiding misdiagnosing these as complicated cysts or hematomas, is to give gadolinium. And you can see this patchy and lacy internal enhancement with the myxoma and similar changes inside of the myxoid liposarcoma. Unless you see fat streaked in the myxoid liposarcoma, which you will see in about 2/3 of myxoid liposarcomas, it's difficult to distinguish myxomas from myxoid sarcomas. What are myxoid tumors about? What they have in common is this myxoid matrix, which are mucopolysaccharoid substances, and you can see them marked by the red asterisks on this histologic slide. And the point is that there's a lot of fluid in these areas, and that's what causes the cystic fluid-like appearance on MR images. Some other pitfalls, and this one's perhaps a bit obscure, but in fact it isn't as rare as it may at first seem. When I'm showing you these areas along the deep fascia posteriorly in the calf, you may say, what's he showing? Oh, there is some slight nodularity, one nodule deep to the fascia. And on T2-weighted images, it looks like fluid. You might wonder if the patient got stung by a bee or something, or if there had been some trauma. But notice these tails of very high signal extending for a long distance. And on longitudinal imaging, it doesn't look like a typical tumor. It looks like something going on with the fascia. But in fact, this is a very deadly type of sarcoma called myxofibrosarcoma. It's a subtype of MFH, described about 15 years ago by the pathologist, and it turns out it's the most common fibrous sarcoma in the extremities of elderly. I realize that's sort of specific, but there are a lot of elderly patients out there, and there's ever-increasing numbers of them, and we see a good number of these cases in our institution. And what's unusual about these, they start out low-grade in many cases, but unlike most low-grade sarcomas, which recur locally, these metastasize, and they spread along fascial and vascular planes, often far beyond the primary tumor. And they often recur relentlessly, and each time they come back, they're higher grade than before. And this is a typical sneaky appearance where it doesn't look necessarily like a nodule, but at 22 months post-op, one shouldn't have a band of linear enhancement in the surgical bed. So we recommended short interval follow-up, and you can see how it's enlarged and starting to become somewhat more mass-like, and this was proven recurrence. And the other thing that's atypical about myxofibrosarcoma is that, unlike most soft tissue sarcomas that metastasize to the lung first, this goes to very unusual places such as pleura, adrenal glands, bone, even to the abdominal wall and peritoneum. So it's to be highly respected. This pitfall patient was referred to us as a chondroblastoma of the apophysis of the humerus. It's a good location, and there's extensive bone marrow edema pattern present. So this would fit beautifully for chondroblastoma. But some of you may have noticed there's abnormal signal in the rotator cuff immediately next to this. So based on that, the patient went on to have a bone scan, and of course it was hot, so everyone's saying, okay, there's a bone tumor. But we said, based on the constellation of findings, rather than jump to the diagnosis of a chondroblastoma, get some plain radiographs, which I'll show you in a moment. And instead of operating, give the patient non-steroidal anti-inflammatories. And that was done, and you can see there's been marked healing of this lesion, resolution of the edema pattern. And what did those radiographs show that allowed us to make that diagnosis? This was nothing more than supraspinatus calcific tendinitis, causing bone erosions. And that's been known for a considerable period of time already, a decade. And marrow involvement is not rare, and it'll be hot on bone scans, so that bone scan does not help you in differentiating this from a tumor. And this was another example of this same process. This was the patient with a small hepatocellular carcinoma in the liver that was treated with surgery, and it was expected to have been a cure. But at 8-month follow-up, there was a new lytic lesion. This was the only change in the chest, abdomen, or pelvis. The only change, a new lytic lesion, and it was said by the unsuspecting radiologist to be suspicious for metastasis. Now, that's not totally unreasonable, but bone metastases are not that common in hepatocellular carcinoma, and to have an isolated bone metastasis as your only manifestation of metastatic disease would be even more uncommon. So the key here was to notice that in the hamstring tendon there was a big glob of calcific tendinitis, which was still present 8 months later after it had eroded into the bone. Before we were able to intervene, the patient went on to have an MRI, which was said to have a lesion, low T1, high T2 signal and enhancement consistent with metastasis, and that's totally reasonable. But if you were to interpret that in light of what the CT showed, one would come up with a very different answer. And in fact, we were able to tell them before they were about to operate on this and cut it out. It should give nonsteroidal anti-inflammatories, and you can see it's almost completely healed by 17 months. So it's important to keep calcific tendinitis in mind when you see a lytic lesion subjacent to a tendon insertion, and this can happen at many tendons in the body. During either the initial workup or subsequently during follow-up of a patient with a known tumor, sometimes other lesions are discovered, and it's always easy to assume that something is another metastatic deposit, but it's important to keep some degree of suspicion. For example, this patient had melanoma, and they were known to have a lung metastasis discovered on CT, so they went on to have PET-CT, which discovered a focus of quite high activity in the region of the right knee. So the patient went on to have a workup of that by MRI, and on MRI it showed this well-defined mass with a very low T2 signal in Hoffa's fat pad, and this is a very characteristic appearance of benign pigmented villonodular synovitis. Lesions that have large amounts of giant cells in them, for example, like this, are known to produce high SUV values and therefore can mimic malignancy. So it's important to, before assuming that something is a metastasis, to work it up somehow. This patient was being worked up for this new small right lung cancer. They had a bone scan which showed a region of activity on this posterior view in an upper right rib, which showed some expansion compared to the contralateral side, but no cortical destruction. But it had a high SUV and therefore was considered suspicious for metastasis, but biopsy showed that it was fibrous dysplasia. So there are various benign pitfalls to keep in mind. This patient was being worked up for a small blastic lesion found in the ischial tuberosity, and the patient did have prostate cancer, unlike Dr. Coakley's case, which they thought had prostate cancer, or had prostate cancer of a low grade. So there was this solitary lesion on CT, and on MR it shows this very small, somewhat spiculated appearing lesion, very nonspecific, but very easy to overlook or just assume to be a small spiculated bone island. But a key finding is present on the T2 weighted image. We see that most of the lesion is low T2 signal, but it has this halo of high T2 signal that shows some enhancement. And here's what it looked like, very small, but for some reason they focused on this lesion because someone noticed it and mentioned it in the CT report as a possible metastasis. They were actually right. Would not have been able to say that based only on the CT scan unless it was a new lesion popping up. But this halo sign is extremely useful. It was reported quite a while ago by Mark Schweitzer, and based on at least the sample of patients in his study population, it was 99.5% specific for the presence of tumor. And here's another example. Bone islands do not show halos. So in the last few minutes, we'll shift now to pitfalls in post-therapy assessment. This was a patient who had a sarcoma in their foot, and at follow-up imaging in the proximal calf, there was this new nodule that was low T1 signal and high T2 signal. Now, it's very easy to say that there's a new mass. This could represent metastatic disease. But when you recognize that you're scanning at the level of the distal stump and you're immediately adjacent to major vessels, meaning that major nerves are running in the same region. This is a typical appearance after amputation where the patient develops a stump neuroma in an attempt to heal the severed nerve. So it's important to at least consider this as the diagnosis, and if it's in the right location near a major vessel and it's well defined and not necrotic or something that would suggest tumor, to say it's probably or a stump neuroma or consistent with stump neuroma and recommend interval follow-up imaging. Another pitfall that applies not only to a bone or soft tissue tumor, but to any tumor. At follow-up, we see on the T1 images that there's this high signal intensity homogeneous fluid. It's easy to say this is all hematoma, and we see it on STIR, very, very bright signal. And the pre and post GADs also look relatively similar, but when you look carefully, posteriorly, there's an enhancing nodule. In fact, that was a recurrent tumor. So to help facilitate the identification of an enhancing area when there's a lot of high signal pre-gadolinium, you can use subtraction imaging. Here's a useful sign when you're looking at muscles trying to decide if there's tumor present or not, if we're just looking at post-treatment changes. On this axial STIR image, I've labeled 3 different areas, 1, 2, and 3. And based on corresponding T1 weighted images, can you say which of these areas has tumor, which doesn't, and why? So I'll ask you, is any of this recurrent tumor, or all of it, or none of it? Well, let's go through. What can you say about this? Just from these images alone, we can see what's called the T1 muscle texture sign, known for a long time, that when you see this marbleized fat streaked like in these other muscles, there is no gross tumor present. Of course, there can be microscopic tumor. There can be microscopic tumor anywhere. But at least in this region, marked 1, we know that we're looking at post-treatment changes. There's no room for there to be any large lump of tumor. Now, in areas 2 and 3, we do not see the muscle texture sign. So are both areas tumor? Are neither areas tumor? Look at the gadolinium. You can instantly see that area 3 is solid tumor. Area 2 didn't have fat, and that may just be because of the post-treatment changes. So, but 3 also doesn't have any fat. So the point is that when you do see a positive T1 muscle texture sign, you can exclude gross fat. But the absence of the T1 muscle texture sign does not mean there's automatically tumor present. There may be tumor present when there's no fat. Another illustration, when you're trying to find recurrent tumor after treatment, these are 2 different levels, T2 weighted images, extensive abnormal signal, some areas looking mass-like. Is any of this recurrent tumor? Is some of this recurrent tumor? None of it? Again, liberal use of gadolinium, unless the patient has a contraindication, of course. A liberal use allows you to readily identify a very early recurrence, which, you can see it on the T2 weighted image, but it's virtually, I'd say it is impossible to pick it out from this background of extensive abnormal changes, but it's relatively simple after gadolinium in most cases. And if you didn't believe that, you can see that at 3-month follow-up that indeed it was shown to represent recurrent tumor. How else can gadolinium help? This was a patient with a sarcoma in the thigh. Pre-op, it had high STIR signal. Post-op, we see this small irregular fluid collection. 2.5 months later, there's a new mass, looks identical to the pre-op image. Very easy to just say, recurrent tumor. But let's look at the gadolinium. Pre-op, the mass enhanced avidly. Post-op, we just see thin linear enhancement along the margin of the seroma. And surprise, this is not recurrent tumor. It could have been if you only had the STIR, but this proves that this is only an enlarging post-op seroma. These seromas are known to wax and wane over time. Don't know why they get bigger, but they can, and it looks nothing like the tumor. So you're able to distinguish recurrence from fluid collections by use of gadolinium. This patient had a soft tissue rhabdomyosarcoma in the calf, and after biopsy and chemotherapy, we can see the mass has virtually completely gone away. However, there's this new mass. Is this recurrent tumor? No, when you give gadolinium, you can see that this is only peripherally enhancing. It's along the biopsy track, and when you look in the surgeon's notes, you see that they use gel foam packing during the biopsy. So this is just simply some gel foam and shouldn't be misinterpreted as recurrent tumor. Another common pitfall in tumor response assessment, which is a very large topic in itself, but just one typical example in the soft tissues, here the mass got bigger, but if you simply measured it and said it got bigger, you'd be giving the wrong answer, because prior to therapy, notice that it was composed of multiple lobules of intermediate signal solid tumor. Afterwards, the amount of solid tumor has markedly gone away, and you're left with these big fluid-filled hemorrhagic or cystic areas in the tumor. So in fact, the patient's gotten considerably better. So overall size changes often don't reflect response accurately. Oops. This patient had a large sarcoma in the buttock. It had some fat in it. It was a myxoid liposarcoma. And this was their follow-up after surgery. And you can see there's just some streaks in the fat posteriorly, and we were saying fine, no recurrence. And looking up higher in the buttock, nothing. And we're about to go on to the next case when suddenly I said, the bladder caught my eye. I said, something's not right with this bladder. It's somewhat heterogeneous in its texture. Usually urine is much more homogeneous in signal. And on the T1, what is this bright white stuff? I mean, it looks like a bladder. It's in the right spot and everything. So we got a CT, and oops, here's the bladder with this enormous metastasis. So the point here is that keep your eyes open at the periphery of the film and always question things if they don't look quite right, because there can be enormous things that are hard to explain why one overlooked when they were in plain view. Last few examples and deal with bones after treatment. This was a patient who had had a Ewing sarcoma in the pelvis, and at follow-up PET, they had new FDG activity in the calcaneus. It was easy to just say this is suspicious for metastasis, but when you look carefully at the corresponding CT image, you can see that it's a sclerotic band of increased sclerotic band, and that's a typical appearance of a calcaneal stress fracture, which can have high activity. This patient had had a low-grade chondrosarcoma in the proximal humerus, and this was a 1999 post-op film. We just saw the cement and the pin. 2002, and they had many intervening films. I'm just giving you some idea of how slowly things changed, but you start seeing a little sclerosis. Hard to make a big case of a problem there. But by 2005, it had gotten bigger, but each time they got their film, they kept saying no change, no change, no change. And by 2009, there was even more, starting to look like rings and broken rings, like chondroid matrix. This is a scenario that we call the no change, no change, no change, oops scenario. And the oops occurs when the person who's reading the later film takes the time, just a few clicks away, to look at one of the earliest films and say, hey, this isn't just post-op change. This is something that's slowly changing over many years. So it's really important to look back, whether bone, soft tissue, liver, anything you're looking at. And of course, this turned out to be recurrent low-grade chondrosarcoma, which was just being watched for year after year, saying no change, no change, no change. Another thing about bone tumors is that often, whether it's a metastasis or a primary bone tumor, before therapy, the patients will often have an extraosseous soft tissue component that may disappear after successful therapy. Then it's hard to know whether the remaining tumor, which often doesn't change in size within the bone, whether this is active tumor, dead tumor, or some combination thereof. In this case, it was shown at pathology to be 98% necrotic, but you can't tell that just by conventional imaging. This is a slide that when I show it to radiologists, they've often come up to me afterwards, and some have told me that this slide upsets them. I didn't come here to try to upset anybody, but it's a very important thing that somehow we tend not to think about. This was a patient with breast cancer metastatic to bone, and she'd had several rounds of chemotherapy. And I'd ask you to think about what would you say about this posterior iliac bone if you were dictating this case. Normal, abnormal, bone mets, not bone mets. Now I'm going to show you the MRI done the exact same day. And I don't know about you, but to me there's a huge discordance. This really shocked me when I saw this pair of studies, because I would have said, I think most of us would have said, there was extensive mixed lytic and blastic change throughout the medullary region of that iliac bone. Yet when you look at the T1 weighted MR image of that same area, there's normal marrow fat throughout nearly the entire region. So there's no gross tumor in any of this except for this 1 centimeter round focus, which could represent viable tumor or dead tumor. So why do these look so different? They're done the same day. Well, you have to remember that MR and CT are not looking at the same thing at all. CT, what you're seeing here is mostly white stuff or holes in the white stuff. You're looking at bone, trabecular bone, cancellous bone. And when we see metastases or any other kind of tumor in the bone, you're seeing changes in the trabeculae, destruction of trabeculae, or host response where you get thickening of trabeculae, sclerosis. So you're often not looking at the tumor directly. Whereas MR, we're not looking at the trabecular bone in most cases. You're really looking at the actual soft tissue marrow composition. And that's the strength of MRI. You're looking at, fatty marrow versus tumor deposits in them. So what the CT can show you as the tumor develops and is getting larger, you can identify it. But often these changes in the bone can persist for months or even years after successful treatment. And if all you say is there's persistent active disease, you'll be giving the wrong answer, whereas MR, by looking at the marrow, shows you something completely different. Another pitfall is in patients who are getting chemotherapy. This was a patient with a sarcoma elsewhere in the body, and at baseline, the humoral marrow looked fine. At 10 weeks, we start seeing some spots. Are these multiple metastases? Is this all metastatic disease infiltrating the marrow? Well, what's important to recognize is that most patients nowadays getting chemotherapies are getting some form of growth factor therapy to stimulate their white cell line. And that reduces the incidence of myelosuppression, neutropenia, and nadir sepsis, which used to be so much more common. But for us radiologists, it's important to recognize that these cause changes that can mimic metastases. They tend not to involve the epiphysis until there's lots of marrow conversion. And the other thing is to have so many metastases suddenly develop during therapy, the patient would be really sick. So that's a clinical clue that you're simply looking at this. At PET scan, these changes cause extensive activity throughout the marrow, and one clue is that the activity in the spleen goes up also. So when you see activity throughout the marrow, this isn't metastatic disease if the spleen is also hot. And the last example in the last few minutes, post-radiation change, the most common type you're all used to is seeing fatty replacement to the marrow on T1 weighted images. But another type occurs where you might think you're looking at a metastasis in the bone here. It shows enhancement. But on corresponding T1 weighted image, you just see some squiggly lines. This is not the appearance of bone metastasis. What is this? Well, we had one opportunity to study this in a patient who was getting pre-op RT to try to shrink this tumor before the operation. 26 days after starting radiation, in the radiated field, we start seeing these changes, progress to these squiggly changes. The patient unfortunately had to have amputation because the tumor had enlarged. And at histopathologic examination, this wasn't marrow necrosis, it wasn't bone necrosis, which we had expected, but rather it was gelatinous or serous transformation of the marrow, which is usually seen in patients with severe cachexia or malnutrition. So in summary, I've tried to show some common pitfalls in evaluating for bone mets, such as over-reliance on bone windows, presence of focal fatty marrow, or calcific tendinitis. Shown you some benign appearing malignant masses, particularly myxoid sarcomas, cystic sarcomas, and sarcomas that mimic hematomas. Always remember in cancer patients they can have benign lesions that may simulate malignancy at imaging. And of course there's the post-treatment changes such as marrow stimulating factors, chemotherapy, and radiation. So thank you for your attention.
So we have a few minutes for questions if anyone has any. There was some online questions. Somebody asked, how do we distinguish focal pancreatitis from pancreatic cancer? And I would say it's really the secondary signs, and also depends a little bit on what type of pancreatitis. If it's focal chronic pancreatitis, I would expect to see chronic pancreatic changes elsewhere in the pancreas. If it's groove pancreatitis, we look for those little dilated tubes and ducts within the abnormality, often best seen on MRI. And then autoimmune pancreatitis, you often have that cocooning or halo sign around the pancreas. You may see secondary findings outside the pancreas. So there's a few little secondary findings that may help you. And then there was another question, David, do you want to take that one about the bone marrow?
It's how to differentiate marrow reconversion from marrow involvement by tumor. It's not always easy, but often the distribution of it can help. Marrow reconversion can be symmetric. You can try other techniques such as in and out of phase imaging of the marrow, because all normal fat, even red marrow, contains some fat in it. So you'll get dropout in some drop of signal on the out of phase images if it's normal marrow, whereas tumors do not contain fat, and those will maintain their signal on the out of phase images. So that would be one technique to use. And you also can look at whether things are going in concert. So if they've had lymphadenopathy that's improving, or they've had lung mets that are improving, it'd be unusual to have a mixed response where the bone mets were getting worse or new ones were developing in the face of other lesions improving. So you try to put the whole clinical scenario together with tumor markers and things like that.
And in the absence of any other questions, I want to thank the speakers again for all of their work and efforts, and thank you, the audience, for your attention, and we will then close this session. Thank you.